up to 30. All right, so the biggest things to remember on musculoskeletal trauma is big bones equal big blood loss. Blood loss, right? Lots of bleeding. So in addition to being mostly painful and being able to cause some tissue damage, the big thing in musculoskeletal trauma is then obviously bleeding. It can cause hypovolemia, hemorrhagic, those kind of things, all right? So injuries to muscles, bones, and joints are very common, all right? Such injuries vary in severity from minor to life-threatening, and proper emergency care can prevent additional damage, okay? Outside of bleeding, really most of our emergency care for musculoskeletal injuries is based kind of more around pain control and preventing further damage, all right? So when it says it can vary in severity from minor to life-threatening, that can be both immediate kind of and long-term, okay? If we look at the 90-year-old woman who falls and breaks her hip, okay, that can kind of be the start of a downward spiral, because then she has to turn sedimentary for a period of time while the hip heals, and then she goes to a rehab facility or skilled nursing where maybe she's not nearly as active as she should, right? And we start to develop problems, blood clots, you know, and the health kind of starts to spiral out of control. So in terms of, it may not necessarily be significant at this point in time when you have them, but being able to kind of self-identify that this could be the start of a downward spiral is kind of important as well, all right? So, some overview of the musculoskeletal system, all right? They obviously give our body shape, and they allow us to be more than just kind of a pile of goo, all right? They protect our internal organs, especially like our rib cage and our sternum, all right? They allow us to move, and we can store salts and other minerals. And they also produce red blood cells, okay? So some fairly important functions here in the musculoskeletal system. We have 3 types of muscle. Remember these, yes? Okay. Voluntary, this is when you want to reach out and slap a friend, okay? The major muscle mass of the body and allows for movement. So the majority of our muscles are voluntary or skeletal muscle, all right? Involuntary or smooth muscle, found inside your internal organs, wrapped around your bronchioles, right? Your digestive tract, all those kind of areas, we find smooth muscle. And then cardiac muscle found only in the heart. That's why we call it cardiac. All right, everybody remember the one thing that sets cardiac muscle apart from everything else?
It can generate its own electrical impulses.
Can generate its own impulse, called automaticity, right? All the rest of these require some sort of input from the nervous system in order to work, all right? So we also have tendons and ligaments, okay? And we have cartilage. Tendons connect what to what? Muscle to bone, and ligaments connect
Bone to bone.
Bone to bone, all right? And then we have cartilage, which is the stuff that's inside our joints. It allows for shock absorption, that kind of thing, all right? There we go, a little picture. We've got ligaments, we've got tendons, and in here will be some cartilage, all right? I don't actually have it in the picture for you, though. So the structure of the joint, okay? Remember, we've got several different types of joint. Here we have the synovial joint, so we've got the synovial membrane, right? So this is kind of a fluid-filled capsule, if you will, all right? It's got the synovial fluid in it, allows it to bend and articulate without grinding or anything like that, all right? We've got some cartilage here, okay? So that allows movement of the joint to, freely and typically pain-free, all right? You start to injure these areas, or over time they start to degrade, things like that. That's when we start to get painful movements, arthritis, those type of deals. So the skeletal system, all right, supports the body, all right. Motion is permitted by joints, all right. So when we have different joints, we have our different motions. Everybody remembers these, right? Flexion, everybody knows how to flex. Extension would be the opposite of flexion. And then we have adduction and abduction, okay. Remember, add is moving towards the body, ab is moving away from the body, and then rotation and circumduction, which is kind of a combination of everything, right? So the different types of injuries that we can suffer to both our bones and our joints, or bones and our joints, all right? We've got fractures, all right? So a break of a bone, all right? We've got strains and sprains, okay? Strains happen to the muscle groups. Sprains happen in the joints, more to the ligaments. Okay. And then we have dislocations where a joint comes out of its normal anatomical position, okay? Most commonly, things like shoulders, kneecaps, that type of deal in what we see, okay? So a fracture is defined as a break in the continuity of a bone, okay? A fracture may be open or closed, all right? So if we have a fracture that does not break the continuity of the skin, that is then a closed fracture, okay? An open fracture then is some sort of fracture where either the bone segment itself or some other related injury has the skin above the fracture site open. The bone can sometimes be protruding through, or it goes through and then goes back in, those kind of things, all right? Obviously, open fractures, they have a greater risk of infection because now we've opened that entire bone cavity and everything up to bacteria in the outside world, okay? So oftentimes open fractures, very often actually, they're gonna require some sort of surgical intervention because they're gonna need to go in and clean, you know, and do antibiotics and all that kind of stuff, okay? The displacement of bones, okay, so if we have a displaced fracture, meaning we fractured the bone and the two pieces kind of went in different directions and they're no longer seated together the way they should be, can often cause damage to surrounding tissues, vessels, nerves, all those kind of things because we have sharp, jagged edges, all right? We tear through muscle tissue, those kind of things. That's why splinting becomes so important, is that we hold that extremity together so that those ends don't go flopping around and tearing through tissue and all that kind of stuff, all right? We've got a couple of different types of fractures here, okay? We've got a couple of, starting from the right here, we've got transverse, okay? So we had a real sharp shearing motion where we've got a complete transection of the bone. It's on a fairly straight line, okay? Here we've got a spiral fracture, usually from some sort of like twisting motion, okay? So we put a twisting force on the bone, and you notice these little fractures are running kind of at angles here. So we've almost like tried to twist the bone apart, okay? We have oblique fracture. Basically, it's kind of like transverse. It's just, it doesn't go on a straight line. It just, the energy followed a little bit different pattern, okay? Green stick, this is where we put a force from kind of the outside. So like if you kind of get your leg hit from the outside playing sports or something like that, as we put the pressure on one side, the back side starts to kind of fracture and shatter apart under the force, all right? So if we had this fracture here, our force would come from right to left, all right, and open up that back side and that would be the start of the break, okay? If you think about it, when you bend like a piece of celery or a pencil or something like that, if you were to slow it down in real slow motion, you see the backside crack first. Impacted, all right? This can happen from a lateral kind of compression of the bone, okay? So when you're talking about, you know, you jump out of a window and you land feet first, all right? That often is an impacted. And then we have the, I can never come in, right?
Complicated.
Yeah, where we've got kind of a series of a bunch of different fractures that have resulted in bone loss or destruction.
Something like a crushing type.
Yeah, yeah, or multiple forces, you know, those kind of things. Absolutely. Questions on those? Perfect. All right, we talked about closed versus open, okay? Continuity of the skin is broken either by the bone itself or by some other type of, you know, soft tissue injury, okay? And then oftentimes the bone can still be protruding out, okay? So if you do have that, you want to make sure you cover that well to help prevent infection. Here's a closed fracture, okay? So you notice we've got a nice little zigzag in the arm here where we shouldn't. Here we have an open fracture. Notice the bone end still protruding from the wound, okay? I think we had a little bit of extra trauma here because this looks a little bit damaged as well. Either that or it's just clotted blood that didn't photograph very well.
What limb is that?
I'm going to say probably like lower leg maybe, but I'm not 100% sure.
You should get the picture of that one basketball player, the college basketball player.
Yeah, it had the floppity flop.
Yeah.
Yeah, I'm not 100% sure. It could be thigh, like if knee is down over here, or this little bubble here could be calf, and we could be using lower. It could be lower leg too. I'm not You have to get more of the picture to, honestly, to grab that.
Yeah.
Yeah, I mean, it could be arm too. I mean, this could be the inside of the elbow. This could be a humerus coming out the end. Who knows?
Kid or something like that.
Yeah.
The same thing, muscle.
Lots of options. All right, so signs and symptoms of a fracture. Obviously, it's going to be very painful. All right, anybody who has ever broken a bone knows that it hurts just a smidge. Okay. Tenderness, which is pain when we palpate it. Good. All right. And when we palpate, we could also see or feel deformities. All right. We can have discoloration. What's that blue color called? Ecchymosis. Good. All right. And we have contusion, which causes the ecchymosis from underneath. All right. Discoloration. Paresthesia, which is yep, right. Kind of. So we could have tingling in our fingers from either some compression or damage to the nerves. All right. We could have anesthesia, meaning numbness, right? So numbness and tingling. Paresis, inability to move, right? So decreased movement, all right? Sometimes this can come from pain, right? Or excuse me, paralysis is going to be decreased movement, all right? Inability to move. Paresis is weakness. There you go. So paresis is weakness, paralysis, the inability to move the extremity. Sometimes this comes just from pain, right? It's too painful to do it, so the patient just won't. Sometimes it comes from an actual reduced ability in the motor function due to the injury itself, all right? We could have a decreased pulse or perfusion, all right? From swelling, right? Damage to the vessels themselves, those kind of things. That's why we always check pulse, motor, and sensory distally on the injured extremity, to make sure that we're still getting those signals through, okay? If we don't, then that becomes a much bigger emergency for us. Here's another fracture. So that's gonna be pretty painful, right? Notice we've got a little bit of discoloration, we've got deformity, all right? So a pathologic fracture involves a diseased bone. Less force is required to fracture the bone. So this is going to be your older population, right? Your geriatric population very commonly has osteoporosis, which is a bone disease that allows for the bone tissue to degenerate, low calcium levels, things like that. And so a lot less force is required to break a bone, right? If one of us were to fall over on the floor this afternoon doing skills, probably not going to break anything. Where somebody with osteoporosis or an advanced age in the geriatric population is probably going to be at a really high risk for breaking something in that process, okay? So some complications of fractures, all right, include hemorrhage, all right? So obviously we've got bleeding in the bone, although it doesn't seem like it is still living tissue, so it's supplied by lots of blood vessels, okay? We can get tissue damage around the fracture site, including nerves and blood vessels. Infection starts to become a big deal, especially if we've got an open fracture, okay? We open that up to the outside world, bacteria can get down in there, and then infection becomes a concern, all right? And an interruption of the blood supply. This is a pretty big deal if it does happen, all right? It's not, super common, all right? But if we interrupt the blood supply because of the angulation or the deformity, or we actually kind of sever an artery or a vein or something like that, then our blood supply chain is going to be interrupted. And that can become very dangerous to the tissue distally, all right? Because we're not getting oxygen, nutrients, and things like that past the injury site to where it needs to go, all right? So we can start to see some tissue death and various other things distally to the injury. Questions on fractures? All right, so a strain, okay, occurs when we overexert or overstretch muscle fibers, okay, and we cause them to tear, all right? So we get a strain in something like a hamstring or a quadricep, right? We've all heard about those in our athletes that we read about and all those kind of things, okay? The pain typically is localized, all right, to the area where the strain is, all right, with not a whole lot of edema or discoloration. Okay, we're just dealing with the muscle fibers. So in this particular injury, we don't have as much involvement of the vessels and nerves and things like that. All right, it's just right there localized to the muscle fiber. So we're going to get some pain because of the damage to the fibers, but we're not going to get nearly as much bleeding and other tissue damage, so we're not going to see nearly as much discoloration and edema with a strain. Okay. A sprain, okay, is an injury to the joint capsule with damage to the connective tissue, usually the ligaments. Okay. So we get very immediate pain and tenderness. All right. And we can also then get some delayed swelling or dislocation. Right. Anybody ever somebody turn their ankle? Yes, I know we've got at least a few of you in here that have probably turned an ankle at some point in time. All right, and it hurts right away. You can't really walk on it, and you go home, and you're like, cool, it's not a big deal. And then you wake up the next morning, and it's like twice the size as it should be, and it's like 14 different shades of purple and blue. Right? Okay, so that's our sprain. All right, we've damaged that capsule within the joint. Okay, and so now we've got either leaking of the fluids, we've got maybe some vessel damage, we've got several different things that then just kind of slowly build up and cause our swelling and our discoloration. Okay? It's actually really fun. Before I got into EMS, I was studying sports medicine, and one of the things that we would do is when you came in, say you had an ankle injury, right, and it was all swollen and bruised and that kind of thing, we lay on your back with your foot up on the wall, right, and we'd sit there and we called it milking, where we'd actually take and like forcefully massage the ankle down towards. The next day the player would come in and all the swelling and everything like that would be up around their calf muscle, because we actually pulled it all away from the injury site so that fresh blood and it could start the healing process. It was really interesting to watch, because you're like doing your thing, like, okay, go, and they come back, either later that day or the next morning, and they'd have the big bruise and ring around their like calf muscle, because we had managed to move it all where it needed away from the joint. So
Well, that's awesome kind of purpose and center that didn't like get around their calf muscle, and
no, there wasn't nearly enough of it to, not enough of it to cause compartment syndrome or anything like that. It hurt like hell when we were doing it. They weren't super big fans of it at the time, but the next day when they were feeling a whole lot better. So
that much trouble, why not just get a lymphatic specialist and drain it all the way up through the groin?
there you go. Because we were a bunch of students, and it's really easy for me to go like this for 20 minutes. Junior college, we didn't have access to those people. So anyway, so moving on, all right. Questions on sprains versus strains, okay? Remember, strains, muscles, right? Pain, no swelling, no discoloration. Strains, right? We're dealing more joint capsules and tendons, or excuse me, ligaments. All right, so we've got discoloration, swelling, those kind of things. All right, so a dislocation. All right, so a dislocation is a displacement of a bone from its normal position in a joint. Okay, so if we think about the way the joint should be situated, now we have bones that are not where they're supposed to be. Okay, this can cause damage to blood vessels and nerves. Okay, obviously the channels and the routes that all the blood vessels and nerves take through your body are set up based around your normal anatomical function. If you put something out of place, you can kink things, pull things, stretch things, cause damage to things. All right. These dislocations can often accompany fractures as well. Okay, so we bring that back into the mix to damage blood vessels and nerves. Okay, it's going to present with a lot of pain, tenderness, and we're not going to be able to manipulate the joint like we should. Okay, it's out of place, so therefore the normal pulling and contraction of muscles is not going to be able to manipulate the joint because it's not able to articulate where it's supposed to be. All right. Ligament or joint capsule damage is very likely. All right. Once the doctors of the emergency department, once they can reduce the injury or put it back in place, oftentimes that can provide for a lot of very immediate pain relief. Okay. Because of the stretching and the pulling of the ligaments and the joint capsule damage, that's likely. Oftentimes, once you've done dislocated something once, you're at a very, very high likelihood of dislocating it again. Yes, sir.
What about double jointed? Like, if your shoulders already pop out easily, but they pop out that
Once it happens once, like you said, it becomes very easy. Some people who have dislocated like a shoulder or a joint or something like that before, they can actually like take it out on purpose. You know,
I can do
put
that.
it back in.
I don't even have to touch them. I can do it.
So I'm really double jointed. Like sometimes around their bolts, whatnot, they pop out and then pop back up.
Yeah. Yeah, a lot of people, once they've dislocated something once or twice, then they've learned well enough how to get it back in, right? And so we don't see them very often unless they can't, right? So we get there and they're like, man, I've done it before and I tried everything I could and today I just can't get it back in. The muscles are guarding, or it went a different direction, you know what I mean? With your shoulder, you can dislocate it anteriorly, posteriorly, that kind of thing. And so they got it out and weren't able to get it back in.
I had mine, this one once go out and then go back in like wrong, but like it was back in, so like we thought it was fine. And I thought like, oh, it's just like pain left over. And then it was like a week later, it was still hurting. I wasn't really moving it. And I like woke up one morning and I like went like this and went boom. Oh, no, it's good now.
Yeah, finally got it where it's supposed to be. Absolutely. So it's fairly impressive to watch, especially if you get some of like the old people that get hips that are out of place. Especially if they're still, they haven't gone through a lot of, they're not super like small and frail, right? So you've got your older folks that still have some of their muscle mass and their girth and that kind of thing to do. It takes a little bit of work, right? Because you've got those big muscle groups of your thigh, right? Your quads, your hamstrings, all that kind of stuff that are all fighting against you, trying to get them back in. I've seen doctors actually like take the patient off the bed and put them on the floor so that they can get the leverage they need to manipulate that back into place. It was really funny in Arizona one time. I transferred a little lady. I think it was a lady. Anyway, a patient, right? Her hip was dislocated. The little community hospital we had at the time, really, they had no on-call ortho or anything like that, and it was the weekend. And so the ED there had tried just about everything they possibly could, and I mean, they consciously sedated her at one point in time. I mean, they threw the book at her trying to get her hip back into place. And they couldn't do it, so they were transferring her up to another hospital where they had on-call ortho over the weekend that could put it back in for her. The ED doc that was on that day, his name was Klaus Gerke. Okay, so you can imagine the type of individual that Klaus Gerke was, right? He was a pretty big dude. And
Do you have a lot of facial hair? Because it sounds like you did.
No, he actually didn't. He was clean shaven. But yeah, big guy, right? And so he was one of those times where he put her on the floor, right, and couldn't get her back in. And so we transferred her up. We got to the other hospital in Chandler, and this little tiny ED doc's all about this big comes in. She's like, "Is this the one they couldn't put in?" She's like taking off her lab coat, and I'm like, "Oh, sweetie." I looked at her, and I'm like, "Honey, you don't stand a chance." I'm like, "Did you talk to the guy that sent her to you?" And she's like, "Yeah." And I'm like, "Did you get his name?" And she's like, "Yeah." I'm like, "What was it?" And she told me. I'm like, "What kind of guy do you think that is?" And she kind of put her lab coat back on and went, "I'll call ortho." I'm like, no, sweetie, you don't even try. Anyway, so dislocations can be a lot of fun. They can look pretty grotesque, right? They obviously typically look a whole lot worse than they actually are on the scale of injuries, all right? Because like I said, once you get them back into place, as long as there's been no actual vessel damage or anything like that, that's pretty much the end of it. Pain goes away pretty quick.
Are you that?
No, sir, not in your scope of practice. You just get to take people to the hospital. So our medical director back in Arizona didn't like that we had a rash of like patella dislocations. So he sat us all down one day in CE and taught us how to do patella dislocations. And then technically, because we were under his direction and he delegated and trained us, we could do those. But very few places actually have the protocol for it, because it varies by how it's dislocated, what's dislocated, all those kind of things. And although we can usually get a pretty good idea of how it's dislocated without an actual x-ray picture of it to show for sure where it is, you can actually do a pretty good amount of damage if you try to put it in the wrong way. So it seems simple enough, right? And one of the only reasons that our doc taught us patellas is because between the patella and the rest of the knee joint, there's no vessels, there's nothing we can really damage putting that one back, right? And it's really easy, there's only one way it goes. Either it goes left or right, and you just push it the opposite direction. But with like shoulders, hips, those kind of things, you really need to get an x-ray first before you try and reduce it. One, to rule out any fractures. Two, to make sure you know where it is so that you can put it back in right. Cool, any other questions? So here's a dislocation of the shoulder joint, okay? So you'll notice the humeral head has rotated. To me, this looks like an anterior or a dislocation to the front, right? So that it's out of joint and sitting in front of where it should be. So like I said, can look pretty funky. Patella dislocations look really funky. Those kind of things. Ankles look pretty gnarly too. Obviously, some calming of the patient when they see what their joint looks like will go a long way as well. So, all right. So some general injury considerations for musculoskeletal injuries. Okay. Just about all of them can present with very similar signs and symptoms. They're all going to hurt. They all might have some swelling. They all might have some discoloration. All right. They all might have a little bit of deformity or something along those lines. All right. So sometimes they can definitely present differently or the same depending on and have different injuries. Okay. So we want to take that into account that just about any time we suspect some sort of musculoskeletal injury, really the exact cause isn't as important as immobilizing the extremity, limiting movement, limiting pain, limiting further damage, and taking them to the hospital where they can take care of them. Okay. Remember, the force that causes musculoskeletal injury may also cause other injuries. Okay, so especially when we start to talk about underlying things, like we talk about our thoracic cavity, right? If I've got a fractured rib, obviously we talked about how I can be at greater risk for lung contusion, pneumothorax, all those kind of things. Okay, so definitely think about the force that was applied, where the force came from, and make sure that you're covering your bases on any other injuries that could happen other than musculoskeletal. Because like we said, except for those cases where there's large amounts of blood loss, cut off distal blood supply, that kind of thing, your musculoskeletal injuries, in general, not all that life-threatening, okay? So, always assess the mechanism of injury and your signs and symptoms, okay? If your signs and symptoms aren't matching up for the injuries that you found, keep looking because there's probably something you missed, okay? So, if you've got a significant mechanism, you're looking at it going, I really don't see that many injuries, but then I mean, my vital signs are crap, all right? Time to start looking for some other things, okay? So that's why when we look at significant mechanism, right, that's one of the things that puts us into head to toe category, because we got to go looking for anything that could have possibly been injured. So our mechanism of injury is going to help kind of determine what injuries we might have, okay? So when we're looking at it, we want to know what it is, not only how strong and how much energy was applied, but then how was it applied, okay? Do we have direct force, meaning I put the force, right, in something blunt like a baseball bat or a pipe or something like that, directly to one specific area, okay? So the area that's injured took the direct force, okay? Could be indirect force, meaning I got my legs swept out from underneath me and as my head's bouncing around, or something along those lines, okay? And then we also have some twisting forces as well, all right? So direct, indirect, and twisting. So critical fractures, these are fractures of the femur or the pelvis, okay? We all know the significance of blood, right? How much can we put in a femur? About a liter or so, maybe a little bit more. How much can we put in a pelvis? Almost up to 2 liters, right? That's a pretty significant amount of blood loss that can show up without any external signs and symptoms, all right? The potential for significant bleeding, these can be very life-threatening due to the blood loss. Looking a little bit at the bone, right? When we talk about blood loss, okay, why do we have so much blood loss? Well, we are very highly vascularized, okay? Remember, we've got spongy bone, which is kind of the honeycomb bone on the end, okay? And then we have the compact bone, which is the real dense, hard bone that creates the marrow channel through the middle of the bone, okay? Marrow channel is where a lot of our vasculature runs, okay? So all the arteries and veins that supply the bone with the oxygen and nutrients and things that it needs for the tissues to continue living, all right, run through there. This marrow cavity and its very rich blood supply is what allows us to use interosseous interjections, right? We have IOs, okay? Anybody heard of the IO, right? We can actually take, nowadays we use like a little drill, like a couple of different ones. Those of you in the military are more familiar with the fast IO or the sternal IO, right? That barbaric thing.
Yeah,
Did they do one in the?
they do it in the PJ. They got one where they cut the shoulder. And then
Yeah, the humeral.
Chest.
Yeah, there's a couple of different. We can talk about them a little bit later. So we can drill in and we actually inject IV fluids and meds directly into the marrow cavity there, where all that nice rich vascularization is. So real quick, real easy. According to the people that have had it done, it's about as painful. The insertion is no more painful than an actual regular IV start. It's once you start trying to introduce fluids into this space, because there is so much stuff in a confined space, right? It's not expandable because of the bone. So when we put large amounts of fluid into it, it increases the pressure and pitches down the nerves and causes an excruciating amount of pain. So the actual drilling in is not that painful. It's once we start putting anything into the cavity that it becomes very painful.
Lovely.
So typically, our general, we're doing those on unconscious people, but I have drilled a few conscious people if, just couldn't get an IV and I needed access, and that was the only way I could get it. So, and when we do like cardiac arrest, it's our first line of IO. We don't even try peripherals anymore in our protocol. We just drill both legs. So our assessment-based approach, all right? We're going to size up the scene for not only safety, but looking for our mechanism of injury, right? How did our patient get injured? All right. Perform a primary assessment as we do on all of our patients. Remember I mentioned we are going to have some pretty dramatic appearance of some of these, right? We saw the ones where the kid's arm goes about 3 different directions in the middle of the forearm. We saw the dislocation. We saw the bone sticking out. All those kind of things, right? None of those as serious as not having an airway, breathing, or circulation, right? So don't get focused in on the dramatic and miss the fact that they're not breathing, have an airway issue, right, or having circulation issues, all right? So make sure you're doing your primary assessment as you do on every single patient, all right? So any life threats or a pulseless or cyanotic extremity require immediate transport after the secondary assessment, okay? So we're gonna wanna kind of bump our transport priority up a little bit if we find any sort of life threat, right? Or if we get through our secondary assessment and while we're doing it, we find a limb that doesn't have pulses, or it's turning blue, or it's getting cold to the touch, something to indicate that our circulation is impaired, all right? For life-threatening conditions, we're going to use a lung backboard to immobilize the patient. Do not split individual injuries prior to transport, okay? So if we get on scene and we've got multiple musculoskeletal injuries, and oh, by the way, maybe they're not breathing so well, so we found the life threat we're having to treat, we throw them on the board, we just make sure all the extremities are extra secure to the board, and we do that as our splinting. We've got time en route to the hospital. Maybe we go back and we split individual injuries. Maybe we don't. We'll let the hospital do it if we don't have time. We're more concerned about the life threats, all right? We're going to perform a rapid or modified secondary assessment as indicated by the patient's conditions, okay? So your standard, ask yourself your questions, determine, do we need to do a focused or do we need to do a rapid head to toe, okay? That still just applies as normal, all right? So decide which one you need to do and do it appropriately, okay? Make sure you're inspecting and palpating the injured extremity, okay? Oftentimes, like we said, a sprain or a strain can present very similar to a fracture, okay? So if you're just looking at it, it may not look any different until you get your hands on it and play around with it and palpate it, and now you can feel crepitus, you can feel bones, misalignment, those kind of things. So make sure you're doing both, okay? We always look and feel. So, paying special attention to our contusions, tenderness, swelling, and discoloration, okay? Also our deformities and our crepitus. So our DCAT, BTLS, quite a few of those come in play here when we're talking about musculoskeletal injuries, okay? Skin color, temperature, and condition, all right? Not only just in general for shock signs and symptoms, but also for either at the injury site or distal to it, okay? Making sure that we have the injury has not impaired any of those functions, all right? So we talked about signs and symptoms of bone and joint injuries, just a little review here. We could have bruising, pain, swelling, deformities, okay? Tenderness, a grating or crepitus, all right? Exposed bone ends, or a joint that is locked into position and cannot be manipulated or is too painful to manipulate, all right? So a quick review of your signs and symptoms there. All right. We have our 6 Ps, okay? So once we've identified a musculoskeletal injury, we want to check for our 6 Ps, right? So pain, all right? Pallor, this can either be global for the patient or to the area distal to the extremity or the injury, so, you know, to indicate decreased blood flow. Paralysis, paresthesia, we talked about those already. Pressure, okay? And pulses, all right? Pressure and pulses are both pretty important things. Obviously, we want to know that blood flow is getting distal from the injury, all right? And if we're starting to build up pressure in the injured extremity, we got to worry a little bit about compartment syndrome, right? Compartment syndrome is when we have so much swelling in an extremity, right, that we start to compress down on vessels and nerves and things like that and impair their function. So there hasn't been actually any damage to them, but the pressure inside the cavity of the extremity has gotten too big and then started to impair, right? So if you're kind of poking on somebody's skin, it's feeling real hard, real taut, and it runs circumferentially, that's going to be kind of a bad sign for you and an indicator of possible compartment syndrome developing. Not usually something that develops immediately. This is going to be more over time, right? So somebody injured themselves the day before, didn't call, didn't go to the doctor. Now they've got this big, super swollen, you know, limb that they can't feel, can't move, right? And it's getting cold to the touch because they're losing blood flow. So our emergency medical care for these folks, okay, is going to be to use our standard precautions. We're going to administer oxygen if needed, right? There's some studies out there that have said increased oxygen levels can provide a little bit of pain relief. When we're talking about a broken bone, we're probably not going to get there with oxygen, okay? But for the basic providers, okay, outside of splinting and cold packs, which are 2 awesome things, oxygen is kind of one of the few tools you have for pain control. So if you want to throw a cannula on somebody, give them a couple liters, right? Sometimes the placebo effect of just having a little extra oxygen and the calming can help. But like I said, there are some studies that say that a little bit of increased oxygen can actually cause you a little bit of pain relief, all right? Being a paramedic with pain medicine in my pocket, I'm not such a big fan of, not a believer of the oxygen, but there are some studies out there, okay? Obviously, if you've got any sort of shock signs or symptoms or any respiratory distress or anything like that, we're going to oxygenate them as needed for those conditions. All right. Maintain inline spinal stabilization if it's indicated. All right. So based off of our mechanism or if our complaint, our musculoskeletal injury happens to be related to the neck or the spine. All right. And then we're going to splint bone and joint injuries, especially if we have isolated injuries. Right. They're not something we're going to rapid transport unless we've got some other signs and symptoms. So we're going to take the time to splint them. Okay. It's going to provide us with pain relief because those bone ends are not going to be grinded together anymore. They're not going to be poking around in the muscle tissue and the nerve endings and all that kind of stuff. It's also going to help help us with bleeding control. All right, we get the bone ends kind of back where they're supposed to be. They kind of hold together a little bit. We're not moving around. We kind of promote clotting, and pain control is definitely a huge one. All right. Apply cold packs to reduce pain and swelling. All right, don't underestimate. All right, the pain relieving abilities of splinting and cold packs. Okay, as ALS providers and with the prevalence of ALS nowadays, we're very, very quick to go to. Excuse me. We're very quick to go to pain medicine. All right, but our pain medicine isn't going to work if we keep increasing the pain stimulus. Right. So our pain medication, puts our pain tolerance levels up a little bit, but if we're not doing anything about what's causing the pain, then our pain medication kind of becomes not so relevant, okay? So splinting, ice packs, those kind of things, the vastly underestimated in their pain relieving and their importance, okay? So make sure that if you've got an injury that you think is musculoskeletal, get it splinted, get some ice on it, right? Get your patient feeling better and prevent that further damage, okay? We're going to elevate the extremity if we can, all right? Don't elevate it unless you've splinted it, okay? We don't want to take that broken arm and be having it waving around up here, holding it up in the air, all right, if we haven't splinted it. And then obviously they're going to need to go to the hospital for further care. When we're reassessing, we're checking our vital signs and our interventions, okay? Also, don't forget distal pulse motor and sensory. Okay, we're going to do it before and after we splint, all right? But we also need to continue to do it to make sure that we're not getting increased swelling the splint we put on isn't doing anything, those kind of things that will impair our pulse motor and our sensation. Okay, so as part of our reassessments, we're going to make sure that we're doing PMS checks when we're reassessing, and we're reassessing under our normal guidelines, right? Critical patients are every 5 minutes, whereas our non-critical are 15, all right? And we're doing our standard reassessment, our vital signs, our physical assessment, checking our interventions, right? Maybe monitoring our ABCs if there was any question on those initially, all those kind of things, okay? Questions on any of that? All right, we're gonna talk about splints a little bit, okay? Splints are used to prevent movement of bone fragments, ends, or dislocated joints to reduce further injury, okay? They not only reduce pain, but they reduce the chances of complications from the actual fracture, okay? Some complications, if we do splinting incorrectly, or even if we do it correctly, sometimes these can happen, all right? We can get damage to muscles, nerves, or blood vessels, okay? We can also have a conversion of a closed fracture to an open one, all right? So if we splint incorrectly, or if we don't splint, okay? If we've got a bone that's sitting just below the skin, it hasn't poked through, so let's say we don't splint it, we allow the motion of it to move around, we can then have that bone fragment push through, and now we've gone from a closed to an open, and we also have now we have an increased infection, a more significant injury that we could have prevented, all right? Restriction of blood flow is obviously not good. We've talked about that, okay? We could also have excessive bleeding, increased pain, and paralysis of the extremities if we're dealing with a spinal injury. So our general rules, okay? So the first thing we're going to do is assess the distal pulse motor and sensory, okay? Before we manipulate it, before we put a splint on it or do anything to it, we want to know what was our baseline when it came to pulse motor and sensory, okay? Was it there, was it not there, all right? We're going to make sure we cut away the clothing and expose the injury site so that we can get a good full examination of it, all right? We're going to place a sterile dressing over any wounds that we have, okay? So if we have an open fracture, we're just going to cover it with a sterile dressing, all right? We're going to align the extremity with gentle traction if there is some severe deformity, absence of the distal pulse, or cyanosis, okay? So if we check that extremity and it's got a real severe, 90-degree bend in it, and we check pulse motor and sensory at the beginning, and it wasn't there, we would need to do our best to try and realign that and reestablish our pulse motor and sensory, okay? So we just gently align as we kind of pull traction, okay? We get one chance to do this. This is the same rules kind of as placing the patient when we're talking about spinal mobilization and putting them in inline position, right? We get one chance to move this extremity. If the patient if we meet resistance, okay, so as we start to move it, it kind of doesn't want to move. We're not going to push against that resistance. We're just going to stop, splint in place, and get to the hospital as fast as we can because we have some distal pulse motor and sensory issues. All right? Or if the patient's pain level is too high, okay, they're screaming in pain, that kind of thing, then we're going to stop as well, okay? Remember, it's not going to be a 100% pain-free endeavor, okay? But if you think the patient is hurting more than they should, the patient tells you to stop, something along those lines, okay, now you got to kind of make a little bit of a judgment call as to when you're going to stop. But severe levels of pain is an indication to stop, all right? One chance. If you can get it aligned to restore it, great. If you can't, splint it in place, give them some LSD and get them to the hospital, right? Okay? We're going to make sure we pad the splint, okay? Some splinting material comes with pads already in place, some doesn't. So if yours doesn't, make sure you're padding between the splint and the actual extremity to make sure that we don't have any pressure points, makes it a little bit more comfortable, that kind of thing, all right? We want to make sure we have the correct size of splint, okay? If we're splinting a bone, so like these guys are doing a tibia and a fibula, all right, then we need to make sure that the joint, both above and below, is included in our splint, okay? If we're doing a joint, let's say we were doing the knee, then our splint needs to include the bones above and below. Does that make sense? Okay? Because if we just put this split from just below the knee to just above the ankle, all right, and that person goes and their foot starts moving around, let's say they can manipulate their ankle, let's say they roll their ankle or start moving their foot around, what happens to the two bones, the tibia and the fibula? They start moving around as well, because in order to manipulate that, there's got to be some movement. Same thing as if we allow them to bend their knee. okay? That causes some movement in those bones as well. All right, so we need to make sure we're doing either the joint or the bones above and below the extremity or the injury site, okay? So if we're doing a bone, it's joint above, joint below. If we're doing a joint, it's bone above, bone below. Sound good? We're going to maintain our manual traction or our stabilization until the splint has been completely applied and secured, okay? Then we can release that traction, and we're going to check distal pulse motor and sensory again after the splint has been put on, okay? And we're going to compare it to our baseline. We want to make sure that nothing we did caused the problem. So if we get that splint on and all of a sudden now we don't have pulse motor and sensory, we need to kind of assess, was it our splint that caused the problem? So we'll go back and we'll look at our splint, we'll look at where things are, make sure there's no pressure points, that kind of thing. All right? So if we have commercially prepared pre-padded splints, then we can skip the padding step. We talked about that. Some have them, some don't. So you just got to make the determination. Okay? We've got some different types of splints. We've got rigid splints, pressure splints, traction splints, and formable splints. We also have vacuum, a sling and swap, spine board, and improvised. All right? So some examples of some splints. All right? Notice we've got the regular old backboard, right? We use a backboard to splint. Neck and back injuries. Also, when we're in life-threatening situations, to splint just about any other injury we find. Okay. Here on the right-hand side, these are the ones that you'll be using here in class. These are our board splints. They are padded, so one side has padding, one side doesn't. So make sure the padded side goes towards your patient. Okay. We've got here. This is a hair traction. This is a Sager traction. All right. They're examples of traction splints, which we use for specifically for femur fractures. Okay. Nowadays, we have a little bit different one that's easier to use. It's called the KTD. You'll see it when we do traction splinting. Okay. We can use pillows and blankets. Okay. Take a pillow, fold it in half, and wrap it around an ankle. You've got the world's easiest and best ankle splint you could possibly imagine. Okay. So don't discount simple things like pillows and blankets. We've got vacuum splints and formable splints here. All right. This is a bipolar traction splint. I don't know why they added that extra picture there. So, some hazards of improper splinting, okay? We can get compressions of the nerves, tissues, or blood vessels if we apply it too tight, allow there to be pressure points, okay? We can delay transport, right? We don't want to do that if we have a critical patient. We can also have reduced distal circulation and aggravation of the injury, all right? If we're not paying close attention to what we're doing while we're splinting, we can either move the extremity excessively during the process of applying it, or if we don't apply it appropriately, we can allow that extremity to continue having excessive movement. All right. We can get skin damage from improper padding. All right. So when we splint the long bone, okay, we apply manual stabilization to the injured extremity. All right. Distal pulse motor and sensory. Okay. We talked about if the deformity is severe. Okay, we want to measure our splint, make sure it's of the proper length. Okay, secure the entire extremity. Okay, if we're involving the hand or the foot, okay, in our splint, we need to immobilize them in the position of function, right? So position of function for our hand is kind of like with a light grip on something. Okay, it's not like flat like here or anything. It's as if we kind of put like if this were a piece of gauze or something like that, just kind of a light squeeze. All right, they don't gotta like grab hold of it, just kind of set it in there to just kind of get their hand in a good position, right? For a foot, we do it at like a 90 degree, okay? So that's our position of function for our foot, just make sure our foot's got that 90 degree angle working and secure it there so that it can't move from that. Redo the systole pulse. When we do a joint, okay, stabilize it, okay? Apply the splint to immobilize above and below. Okay, we talked about that already. Huh? If we typically go with position found, okay, just because we don't want to manipulate it if there is an injury within it, okay. So if we can do position found, we'll leave it there, all right. If we don't have pulse motor sensory, that kind of thing, then oftentimes we'll try and straighten it under those rules there. But you know, this guy here, if he's got a knee injury, all right, and he's got positive distal pulse motor sensory, we're just going to do position found. So, traction splinting, all right? Traction splinting is used For femur fractures and femur fractures only, right? Isolated femur fractures. If we've got another fracture to the knee, the lower leg, the ankle, anything like that, if we suspect a pelvic or a hip fracture, traction splints are out, we'll just split the femur like we normally would or any other joint, okay? So isolated femur fracture, all right? Femur fractures can be accompanied by bleeding, pain, and pretty severe muscle spasm. Remember, we've got two of the biggest muscle groups there on the upper leg, all right? When they spasm and contract in response to the injury, if those bone ends have separated, right, and all it does is dig into muscles, it causes it to be very, very painful, okay? Using traction to align the femur can then reduce these complications. We basically kind of artificially pull against the muscle spasm. Sometimes it'll relax a little bit once we've done it, but either way, we kind of pull those bones back into alignment and we hold them there so that way they're not digging in, doing damage, causing pain, those kind of things, okay? We're going to treat for a femur fracture if the thigh is painful, swollen, or deformed, okay? Remember, isolated only. If we got any other injuries on that extremity, we're not going to use the traction splint, okay? So the rules from the book: do not use traction splint if the injury is within 1 to 2 inches of the knee or the ankle, okay? If the knee has been injured, the hip has been injured, the pelvis has been injured, or there's partial amputation or avulsion, okay? The reason for that, all right, is because when we pull traction, we're using the hip as our anchor point, okay? Doesn't matter which device we use, they all use that hip as an anchor point, and the pull point is on the ankle, okay? So we're going to be literally kind of pulling the extremity to make it a little bit longer. If our hip is broken or our pelvis is broken, we go and push on that and use it as an anchor point. What are we going to do to that injury? Could cause it to get worse or do more damage. Same thing with the knee and the ankle, right? We wrap a little hitch around the ankle. If the ankle's busted and we go and pull on it, we could actually cause more damage to the ankle or the knee, that kind of thing. That's why we use it very specifically for isolated femur fractures, okay? Our traction splints come in 2 different types. They have unipolar or bipolar, okay? We saw the bipolar one earlier, which was the hair traction splint. It was on the left side of the picture. On the right side was one of the unipoles, which is the Sager splint, and the, KTD, which we use here, okay, is another example of the unipolar device, all right? So, pelvic fracture associated with pain and significant bleeding, okay? Splinting methods include, we can use the PASG if you have them. You just inflate the pelvic region only, all right? We can have also commercial splints or improvised, right? There are commercial pelvic binders out there. You wrap them around, you pull on them, and they're designed to kind of give way when the appropriate amount of pressure has been applied, and then you secure them, right? So you can't over-pressurize them. Improvised splints, we use either like sheets, pillowcases, that kind of thing, to tie, all right? Here's the example of a commercial type pelvic splint, okay? Remember, pelvis is down a little far lower than you think it is, okay? Don't put your pelvis up too high, because if you just get the top of the wings and you spread the bottom part open, then that's gonna, you squeeze up top and the bottom spreads, that's not gonna do your patient any good. Compartment syndrome, we're talking about this, where pressure develops with inside the injured area, okay? The pressure exceeds the capillary pressure needed to perfuse the tissues. The tissue becomes hypoxic because we've collapsed those vessels down, and they capillary can't get gas exchange, can't get blood. So we get hypoxic, which results in further damage and swelling, okay? So some of our signs and symptoms: severe pain, we can get a burning sensation, all right? Decreased strength in the extremity, paralysis, pain with movement, the extremity feels hard to palpation, and we have abnormal distal pulse motor and sensory, okay? So we've got our normal musculoskeletal things, and then the big things are gonna be burning, all right? We could also get a hard touch, all right? And then distal pulse motor and sensory may be abnormal. Those are kind of some of your things that you're going to look for that set your compartment syndrome patients apart from your normal musculoskeletal injuries. For compartment syndrome, we're going to splint, right? Because obviously we've got some sort of underlying injury. We're going to elevate to try and get the gravity to kind of help us out with relieving a little bit of that pressure. We're going to apply cold packs, and we're going to transport to the hospital. And that is the end of musculoskeletal.